Dear chairs, dear colleagues, first of all, thank you very much, Zoltán, for your kind invitation. It's a pleasure to be here. And thanks for the topic. It's a very interesting topic worth talking about because as you will see, thank you, sepsis is responsible for 20% of global deaths. Yes, we know that. But this data originates mostly from the hospital records. And what about patients not reaching the hospital? So probably the data are much higher. Where can we have meaningful data from? It's, for example, the Global Burden of Disease study involved 150 countries. And according to their data, there seems to be a declining age-standardized incidence and mortality in sepsis. Nevertheless, sepsis remains major cause of health loss worldwide. What is important to emphasize that if you have a look at the graph, you can see with red the sepsis used primarily to infection origin. That means the patient was admitted to hospital due to infection. But we have two different graphs as well. The blue one, which is due to non-communicable diseases, that means that the patient was admitted to the hospital due to hypertension, diabetes, cardiomyopathy, tumor, and so on, and get infected there, and that's how he will die in sepsis later on. And the yellow line is very important. This is sepsis, which starts first due to injury, and this is, you can see that this line is oscillating, which is quite tragic, because this oscillation is usually due to wars and genocides. One of them is, for example, the Rwanda genocide with 1 million dead people. Most of them died due to trauma and sepsis later on. So it's not always infection that starts, well, it's always infection that will lead to the sepsis, but it's not always the starting disease. It seems that sepsis mortality is decreasing, but it's not correct, the sentence like that. Because if we control the studies for the severity at the time of admission, there is no significant change in mortality of sepsis. So the reason for the reduced mortality seems to be the increased awareness. The patients get to the hospital earlier. Why? Because we were focusing on how to define, how to find these patients, and we have quite good definitions. We know that this was a challenge. But now we arrived to the life-threatening organ dysfunction caused by a dysregulated host response to infection. To infection, it's important to emphasize this because once we get to the dysregulated host response phase, we got stuck. If we want to treat sepsis per se, the drugs don't work. Have a look at how many drugs were withdrawn for the market or stopped due to increased mortality sometimes. So for the moment, what we do know is how to treat an infection. Early diagnosis, infections, source control, antimicrobial, and surgical. And if you check the 93 recommendations of the Surviving Sepsis campaign, 15 of them, strong recommendations, will deal with how to keep the patient alive. This is mainly supportive care and giving antibiotics and treating the infection. So in the Surviving Sepsis campaign, we are talking about treating the infection and keeping the patient alive. What we are still learning about sepsis, that there are no sepsis-specific interventions for the moment because they could not significantly improve mortality, or in fact, sometimes they can even worsen it. So the best tactic for the moment is be on time. How to be on time? Well, it's a different question inside the ICU and outside the ICU. Inside the ICU, it's quite an easy question because we are 7 per 24 hours by the bedside and we are monitoring the patient, and our first question is, how is the patient? Quite an important question. You can see that even the SOFA score does not have a big specificity or a sensitivity within the ICU. But the main question is not inside the ICU, but outside the ICU, recognizing the patient in need. And for that, for the moment, quick SOFA seems to be a good beginning point with an area under the curve about 0.8. So just checking patients who have tachypnea, systolic hypotension, and altered mental state for the signs of infection, that's already a good beginning point. And when we can see that there is trouble, then we have to act very quickly according to a checklist. The checklist is, first of all, how to keep the patient alive, and for this, an ABCDE approach seems to be quite okay. So just as the pilots, we go through ABCDE and stabilize the patient, and we win time for a proper diagnostics. Proper diagnostics is crucial because we cannot treat sepsis, but we can treat the infection, so we have to find the infective agent. And finding the infective agent also means finding the infectologist who is responsible for the intensive care units, because not all of us are experts in infectology. Some of us, yes, but some of us, no. And this study is very important because you can see that the presence of an infectologist on the ward rounds regularly can decrease the mortality of the sepsis with 40%. So if we can treat directly the infection correctly, that's a big help. The next step, be quick and be there by the bedside. And for that, staffing problems. That's crucial. What about the staffing in our hospital? Have a look at first the general ward, surgical ward. Each additional patient per nurse is associated with 12% higher odds of in-hospital mortality in sepsis. They simply just don't get there in time. And what about the intensive care unit? It's even more marked. The risk of death was increased by 3.5 when the patient-to-nurse ratio was greater than 2.5. In Hungary, we are in this range at the moment, and if we have a look at Europe, most of European countries are almost in this range. So if we are thinking about sepsis, staffing problems is one of the first to solve. Healthcare-associated infections, we go in this direction on. This is one of the most common adverse events during care, affecting hundreds of millions of patients worldwide each year. So the healthcare workers are a source of sepsis as well. While low-income countries, you can see that it's primarily the infections that will cause high septic mortality. In high-income countries, the non-communicable diseases with septic complications will cause the mortality. So sepsis happens in the hospital due to hospital care for patients who were not admitted to the hospital with infection diseases, but they will get the infection in the hospital. So we have a major role in this part because this is a spot where we can help. And how can we help? First, we have to understand why the hospital is involved in so many septic cases and so many infections. Because in the hospital, we are living with our bugs. The hospital per se is not infected. It's the patient who gets there who is infected. And once the microbiome of the patient gets disturbed due to a critical illness, and we do know that we are 10% human and 90% microbes, and dysbiosis will happen as soon as we get critically ill, the surrounding of the patient will change. And this is typical how it will change. Staphylococcus aureus usually dominates the upper part, and gut microbes, Acinetobacter, Klebsiella, and Pseudomonas, the lower part of the bed. On the ultrasound machine, you have the Pseudomonas and the Staphylococcus as well. It depends where the doctor worked previously. And regarding how many free ICU beds you have and infection control, you do need free ICU beds. You have to isolate the patient. And you have to pay attention what is the change of patients within your ICU, because if it's too quick, there is not enough time for proper sterilization of the surrounding, then the patient who will receive the bed from a prior patient carrying bacteria will be exposed to an increased risk with odds ratio 2.1 of being colonized and potentially infected by the same bacterial species. Regarding the dysbiosis in the critically ill, we might say that it's the hospital per se who is infected. No, it's the patient who is infected, because we who spend most of our life within the walls of the hospital, our microbes, if we are healthy, are totally normal. On the picture you can see the oropharynx microbes for hospital workers and civilians who are outside the hospital. And have a look at, once you get ill, that will happen, that the pathogens will dominate the commensal flora which is in your oropharynx. And the iller you are, the more critically ill you are, the situation will be worse. What can we do? Do we do, for example, a simple thing like the 5 moments of hand hygiene each time by each patient bed? Do we pay attention to that? Well, this was one of the first things that came into our mind when we made an audit in our ICU a few years ago, and this is the PhD work of one of my kind colleagues. And the problem was that we made regular audits on our ICU, and we could see that the incidence of ventilator-associated pneumonia is going up. And we tried to figure what can be in the background, and the first question was hand hygiene. And you can check the hand hygiene adherence. You can see that it was really, really bad, and doctors dominated in this. Physiotherapists could wash their hands perfectly fine, but not the doctors. We were the last on the row. And how could we check it? This is the Semmelweis machine with a special liquid. You can check the fluorescence, whether you have covered all your hand with disinfective agents or not. And we went through education and teaching and practicing, and you can see that in the post-implementation period, the cumulative risk of ventilator-associated pneumonia at once went down. But knowledge is obsolete. The problem was that once we taught everybody regarding how to make better hand hygiene, then the compliance was quite good, and then it fell after 12 months it went back to almost worse than at the beginning. And parallel to this, you can see that the incidence of ventilator-associated pneumonia went up again. It dropped first and went up again. So refresher courses cannot be overemphasized in this situation. So regarding the changing epidemiology of sepsis, I would like to emphasize that nosocomial infections and our task is getting more and more significant. Sepsis mortality can be decreased with increased awareness. So if we accept that we have a role how sepsis epidemiology will change within the hospitals, then we have also to accept that we have to be aware of this. We have to pay attention to the staffing. We do need enough nurses and enough doctors on the ward. We do need enough beds on the ward to be able to clean properly between the patients. We do have to focus on the hand hygiene and infection prevention control programs, which has to be re-educated, and regular education cannot be overemphasized. And with this, I would like to thank you for your attention.